You know, in my slides, generally on talks, I have a slide at the end where I talk about what we can do together. It always starts with eliminating patient harm. Let me quickly call out 5 areas for us to think about. One is setting clear aims and goals, and I think when Don Berwick was administrator at CMS, we started a cross-federal government and cross-private sector effort really focused on eliminating patient harm. Those results Rick may speak more about. From 2010 to 2014, significant reduction in patient harm across this country. This is ARC National Scorecard data, which I'll let Rick talk about. Estimated 87,000 lives saved, 2.1 million injuries, infections, and adverse events avoided, and approximately $20 billion in cost savings. So the good news is significant reductions in harm. The challenge is we're still at about 120 per 1,000 people that have a harm event, and this is just the inpatient setting. Then you extend that out to outpatient and other settings. So it's really how do you focus on eliminating harm in the inpatient setting across the board, not just academic medical centers, and then how do you also focus across settings for the whole health system. 2, quality improvement, what I'll call learning collaboratives and technical support. So our biggest investment has been Partnership for Patients, where we put in approximately $500 million in growing to focus on patient safety, working now with hospitals that represent 80% of the U.S. population, and we think that was a major contributor to the results that I just spoke to. Still need to continue, in my opinion, on how we focus on learning collaboratives that are maximally effective, which does get to things like high reliability methods, learning with data, et cetera. 3, I'll call out the science of improvement. So I think Rick may speak more about this from the HRQ perspective, but I think the science of improvement, both evidence-based practices and then high reliability methods about how you get them into practice all the time. I still remember as a trainee the infant that passed away from a central line infection at the time, the attending saying these things happen, they're not preventable, which is what people thought at the time. We now know they're preventable, and we're preventing them to a large extent at a national scale. But it's how do you spread that learning to other areas of harm? How do you build the evidence base for the next generation of harm prevention? The 4th area I'll call out is the various payment models. So we increasingly at CMS are linking payment through value-based purchasing programs to quality and cost results, including patient safety is a major focus. At times we've been accused of double dinging people for putting certain measures in programs. We really view this as, you know, we have a focus on patient safety, therefore we're going to put validated, reliable measures into payment programs whenever we can. Also alternative payment models, so whether it's ACOs or primary care medical homes or bundled payment, there's a focus on evidence-based care delivery and preventing complications and harm. The last area I'll call out is transparency. Actually, just about an hour ago, we put out the next release of the Hospital Compare, including measures on patient safety and updating those results. The HAC, actually the Healthcare Acquired Condition Program, sorry to not use acronyms, results just went out today. And then Physician Compare for, this is the largest physician release of quality data we've ever had, so down to even the individual physician level and many more measures on groups of physicians. Still work to do on measurement and measures that matter and outcome-oriented measures, et cetera, but we have a major focus on transparency. We know that transparency can both empower consumers and, I think, importantly, drive improvement at the provider level. So lastly, and I will end with a little extra time, so you won't have to tap me. I'm a practicing physician. I practice in the hospital medicine setting. Not this weekend, but the next weekend, I'll be there. At its core, we need a highly reliable system that prevents harm in all settings across the U.S. When I left Cincinnati, and they've done better work since I left, I didn't mean that as a joke, although it sounds like I was the barrier. We had gone 1,500 days without a code, with no codes outside the ICU, and it was high reliability methods, detecting clinical deterioration and intervening. And there's really an issue of we need a system across our health system that every practitioner, clinician, physician can be successful in doing what they want to do, which is eliminating patient harm.
Well, thank you. Thank you very much. Remarkably efficient use of time. Sorry.